There are two different IDH2 mutations. The IDH140 occurs in about 75% of IDH2 mutants, and there's another one called the R172 that's present in the other 25%. They are a little bit different in terms of co-occurring mutations. The IDH2 R140 tends to co-occur most with splicing factor mutations, SRSF2, as well as DNMT3A mutations. RUNX1 goes along with the patient story we discussed that had the DNMT3A and the RUNX1 mutation. Both of the IDH mutations, though, are targeted by enasidenib, the IDH2 inhibitor. So both of those are appropriate for treatment with an IDH2 inhibitor. The IDH2 mutations occur overall in about 12 to 15% of patients with AML. So it is not the majority, but it's certainly a sizable percentage of AML patients. And the older a patient is, the more likely they are to have an IDH2 mutation. So especially in older patients that may not be candidates for intensive chemotherapy or that have relapse disease after therapeutic options, the IDH testing is important because many of your patients may be eligible for IDH2 therapy. The prognostic significance of IDH2 mutations in general is null, meaning that there's not a particularly favorable or unfavorable risk or prognosis associated with the presence of an IDH2 mutation. There are a few nuances. There are patients with IDH2 R172K mutations that are thought to be particularly favorable. IDH2 mutations do co-occur with NPM1 mutations, and when that happens, those patients are thought to be particularly favorable also. But in general, they tend to do kind of as well or as poorly as other patients with AML. The important thing about IDH2 mutations is not the prognostic significance in and of itself, but the fact that there are now targeted therapies available for these patients. So that's the importance of the knowledge of IDH mutations.